Hello, everyone, and welcome to Cottage Health's virtual Meet the Doctor. Today's talk features Dr. Brian Walcott, a board-certified neurosurgeon at the Cottage Neurosciences Clinic. I'm Christina Cortez, Public Relations Manager for Cottage Health, and your moderator for this session. Thank you all for being here today. Before we get started, I'd like to review a couple of housekeeping items to help make the most of your experience. At the end of this presentation, we'll host a question and answer session. Please use the Q&A button at the bottom of your screen to submit your questions. Please also note that this presentation is being recorded and you will receive an email within the next week with a link to view the presentation and PowerPoint slides. Now it's my pleasure to introduce Dr. Brian Walcott. Dr. Walcott is a board-certified neurosurgeon with a primary focus on vascular disease and tumors of the brain and spine. He completed his medical education at Loyola University, Chicago, followed by neurological surgery residency training at the Massachusetts General Hospital, Harvard Medical School. Subsequently, he honed his expertise through fellowships in neurovascular surgery at the University of California, San Francisco, and endovascular neurosurgery at the University of Southern California. Dr. Walcott specializes in minimally invasive image-guided techniques to deliver evidence-based care for patients in the catheterization lab, the operating room, and during focused radiation treatments. We're so glad to have Dr. Walcott with us today, so now please join me in welcoming him.
Hi, everyone. I'm Brian Walcott. I'm one of the neurosurgeons here at Cottage, and I want to thank everybody for coming to this presentation and question and answer session. I want to make it kind of as interactive as possible. We're going to have some time for questions at the end, and I'm a very casual person, and I'd like to get as many questions from folks as possible. I know there's lots of my patients that are on the talk today, and I want to send out a special thank you to everybody that could make it. So the purpose of the talk today is really twofold. One, of course, I'd like to talk about brain aneurysms and to give kind of an educational talk to people from a very practical standpoint about what aneurysms are and how we fix aneurysms and what we offer here at Cottage. And the second part that I was just thinking about is it's really an introduction for me that I can kind of show you guys a little bit about who I am, kind of what I do in the hospital. I see many people around and many familiar faces, but this is kind of my corner of the world. It's a very, very small corner, focused, but it's something that I really enjoy, and it's something that I'm really enthusiastic about. Anybody that knows me knows that I'm passionate about neurovascular care and aneurysms. And so two parts to this talk. It's really educational, and then I'd like to kind of use it as an introduction to myself. So aneurysms are not actually super rare. If you were to take everybody at the grocery store and put them into a CT scanner or an MRI scanner and try to figure out how many people have an aneurysm that don't even know it, it's probably somewhere on the order of 1 to 3% of people. And there were some actually very famous studies that were done up at the Mayo Clinic many decades ago when autopsies were very common. And they looked at what percentage of people had a brain aneurysm on their autopsy, and the number is a lot higher than people think. And so aneurysms are not a terribly rare thing, but for an aneurysm to burst, it's much less common. And so in a general sense, we have arteries all throughout our body, and it delivers blood flow and nutrients and takes away the waste from our body, whether it's our fingertips, down our legs, or our brain. And the brain actually gets a lot of blood flow. It's constantly working. It takes up a lot of energy, glucose, and the metabolism is quite high in the brain. So there's actually a good deal of your blood flow, the amount of blood that's pumped out of your heart actually goes directly to your brain. And there's a whole tree of arteries. It actually looks like a tree. It starts off with a big trunk in your neck, the carotid arteries, and then it makes branches as it goes up into smaller and smaller, tiny little blood vessels. And they get very, very small, smaller than a millimeter towards the surface. And then it drains back in the veins and heads back to your heart, only to be pumped out again and again over and over throughout the day. And so these arteries are very similar to arteries throughout our body, but they get this it's kind of like this high flow situation where they get more blood flow than other parts of our body for the most part. And for different reasons, sometimes you can get a bulge in the artery, a weak spot. And because of blood pressure and because of this high flow situation, you can actually get a bulge, and that's what an aneurysm really is. It's a bulge on a blood vessel. And it typically happens when an artery is trying to take a turn, and that's typically where the weak parts are in the wall. Doesn't always have to be the case, just speaking in generalities. But it's this kind of bulge, and they tend to get bigger over time too, especially if they're at a certain size. And so, like I said, most people don't know that they have an aneurysm if they do have one, and they don't cause symptoms, they don't cause trouble at all. The only trouble really comes from is if they get bigger in size and they burst. And when they burst, it causes bleeding in the area around the brain tissue or even in the brain tissue. And this could be really, really serious. Some of the sickest people in the hospital are the ones that have ruptured brain aneurysms. The condition is called subarachnoid hemorrhage, and it's a life-threatening condition, and so that's why these people need to seek care immediately. But even though aneurysms can be really dangerous and scary in terms of when they burst, I would say that the majority of the aneurysms that I see on a daily basis are ones that we're either watching in clinic to make sure that they don't misbehave, or we're repairing them before they cause trouble. If they do burst, we take care of those people in the hospital, the intensive care unit, and do the best that we can for them. And the talk today is really focused on these minimally invasive techniques that we have to fix brain aneurysms. And a lot has changed over the past 20 years or so. And I would say that I'm in a very unique position. I've been outside of training now for over 10 years. And training itself was 10 years long too. So I'm basically at the 20-year mark now since I started kind of with neurosurgery. And when I started, aneurysm treatment was completely different, 180 degrees different than what it is now. And so I'll walk you through some of the changes that have happened, and to talk about how aneurysm treatment is a lot safer now and is a lot more less invasive, less taxing on patients. And I guess I'm just a safety guy. Safety is the number one thing for me, and I would say it's just much, much more safe now. And there's data that backs that up too. So this is a drawing that I made of an aneurysm. It's not terribly complicated. Some aneurysms are very complicated. This is a very simplistic rendition of one, just a little sketch. But this little bulge here, it should be, a straight tube, your artery. And this bulge that kind of comes out on the side there, that's what we treat as an aneurysm. That's the definition of one. And 20 years ago, maybe 25 years ago, the only way to really fix an aneurysm was with a very traditional surgery, coming from the outside in on the side of your head. And we would use it's kind of like a clothespin or a clip that you use to close the potato chip bag. Very small one under the microscope, but that's what would be used to pinch off the aneurysm. And this is a kind of a picture of it. It's an artist rendition of it. The clip opens up, and then you put it across the bottom of the aneurysm, and that seals it off from the blood flow. And that keeps it from bursting and makes it kind of shrivel up and go away actually over time. And so almost 100% of aneurysms were treated this way over 2 decades ago. And it's a very effective way to treat aneurysms. I still clip some aneurysms where I think that that's going to be the safest and most effective way to treat them. But it's much less common now, and there's much less people that are skilled and kind of capable of doing this even to this day, just because it's less common. So kind of the technique to get to the blood vessels in the brain, and I'm explaining it to someone as if they were a family member not in medicine or a friend. Most of the work is done kind of right behind the eye here. And we use it's like a small jigsaw to make a window through the skull bone. And then under the microscope and under the brain itself, we are able to go in underneath and find those blood vessels as they're coming up through the bottom of the skull into the brain, because that's where most of the aneurysms form. And we put those little pinch clips on. And so on the left, you can see the size of the window that you need for like a very kind of complicated aneurysm. It's bigger size, bigger incision, more taxing on the patients. And it's not a minimally invasive thing. It's actually quite invasive. It's probably the most, next to cardiac surgery and having surgery on your heart, it's probably one of the most invasive things that you can have in your body. The technique has been refined sometimes for simpler aneurysms, and depending on the way that the aneurysm looks and is shaped and things like that, we were able to make smaller incisions and smaller bone openings. But nevertheless, it still involved a traditional surgery with a scalpel and coming from the outside in. And so it's a big thing to go through. I'm sure there's people that are listening today that have been through it, and it's not a simple thing. But when I started practice, this was the only way really that we had to fix aneurysms. And so I'm a visual person, and I learn by looking at things. And so I'm going to show you a couple pictures and kind of illustrations from patients that I've taken care of, obviously anonymized and kind of for talk purposes. But this is to kind of show you like what I do at work, because I'm not even sure my family or wife or kids will ever really appreciate. But if you see these pictures, this is kind of like the area that I work in the brain. This is what I do in the world, actually. So this is a patient that had a ruptured brain aneurysm, and the red circles are around the small abnormality, the little bulge in the blood vessel. And that's how we detect things. So we do these special studies called angiograms, where we take some dye and we put it inside of the blood vessels, and then we take x-rays. And that enables us to see the arteries with really, really good detail and really, really good precision. And that's how we can figure out what's going on. Like, for example, if someone comes to the emergency room and we're worried that they've had a brain hemorrhage, that's kind of the first test that they get. And so this is under very super high power magnification under the microscope. This is kind of in the fold of the brain tissue itself. And this is a middle cerebral artery aneurysm. And on the top right, my little pointer tool there that I use to help kind of delicately move things around is pointing to the bottom of the aneurysm. It's this small little bulge that's at the top of the branch point where the tree branches head off into the brain tissue. And that's the problem that needs to be fixed. And so on the bottom left, I've already put that little pinch clamp on. It's kind of hard to make sense of it on a photograph, so you'll have to take my word for it. But those little teeth kind of slide across the bottom of the aneurysm and seal it off and fix it. And then we give some fluorescent dye in the vein, and then there's a special filter that we use with our glasses under the microscope. And that lets us see blood flow in real time. It's like a movie of how the blood's flowing through, and it's bright yellow. And so that gives us some confirmation that the arteries are okay and that everything is safe with that. And it also lets us know that there's no more blood flow into the aneurysm itself. So mission accomplished. Once those two things are done, the case then you know the case is solved and your work is finished. And so patient went on to have actually an awesome recovery. And it's interesting because I can still remember almost every case that I've ever done, even though I'm probably close to 1,000 aneurysms now. Just by looking at the pictures, I can put a face with the angiogram and the pictures intraoperatively. It's such a serious thing and such a profound kind of operation that the memories are kind of instilled in you forever. Here's another type of aneurysm. This one's in the back part of the head. And on the left side of the screen, it's not so much the little bulge that I showed that little sketch from. This one is actually, it's more like a sausage. And it affects a longer segment of the artery. It's not just on one little part, it's a longer piece. And there's no real good way to fix that with like a pinch clamp. You don't want to seal it off because then you're going to probably seal off the good blood flow to the brain too. And so one of the things that I know how to do, I trained and probably have some of the most experience in that area in the state where that is bypass surgery. And so this is under very, very high magnification. This artery, the picture of the artery there is only about 1.5 millimeters in thickness. And so those little stitches that are there, those little black stitches are actually thinner than a human hair. Certainly thinner than my hair because mine's kind of disappearing, but those stitches are very, very fine. You can really only see them under the microscope. But what we're able to do is to actually just kind of cut out the aneurysm, the disease part of the blood vessel, and then sew it back together under the microscope in what's called bypass surgery. And that's one of the things, in addition to clipping, that's another way to fix an aneurysm that it's kind of like part of the toolbox that you have in case you need it. It's not a very common thing, but when you do need it, you want to have all the skills ready for it. You want to be able to sit down and understand when the indication is for it, and to be able to perform the technical aspects of it very, very surely and very safely. So clipping, bypass surgery, and now kind of the meat of the talk is using image guidance or minimally invasive surgery to repair aneurysms. And this is how probably 95% of aneurysms in my practice are treated now. And we'll go through case examples again. But it's really a fundamental shift because before everything used to be with my eyes and my hands directly. And now with image guidance, it's really based on what we see with the x-rays and doing surgery on the inside of the blood vessels with things called catheters and wires and coils and stents and things like that. And so it's a fundamental shift. It's switching from what you can see with your eyes under the microscope So kind of like what you see with x-rays and everything on the inside of the blood vessel. This is a picture of the robot that we use. It's a really sophisticated and probably very expensive robot. Actually, don't know how much they cost, but it's certainly very expensive. And it takes x-rays at the same time in two directions. So it takes x-rays from front to back, and it takes x-rays from side to side. And it displays them on this really nice TV monitor that's in front of you. And I guess we've trained our brain. I actually haven't thought about this before, but we've actually trained our brain to look at those two different pictures that are in two different planes, two different angles. And then inside of when I'm looking at the screen, I reconstruct that in 3 dimensions. And that helps us to steer little wires and catheters into the brain. But it's kind of like part robot, so that takes the pictures, and then it's human too, because my brain has to kind of understand what that looks like in 3D space, and then figure out which way things are going from there. So robot, super cool, changed practice forever for neurosurgery. And basically it's a lot of x-rays and a lot of dye, but it makes things a lot safer. So one of the first things that were first applications in terms of endovascular treatment of aneurysms was something called aneurysm coiling. And one of the first cases was actually done down at UCLA by the person that taught me how to do aneurysm coiling. And it involves placing this kind of fine thread, it's like a metal alloy, fine thread through a small tube on the inside of the blood vessel, all the way up into the aneurysm, and lightly packing it in there. And that keeps blood from flowing in there, and it seals it off. And so, fundamental shift, because surgery used to be the pinch clamp that came from the outside in. This technique is from the inside, and you fill it with this kind of coil material to seal it off. So on the top, that's kind of like before treatment. And then on the bottom of the screen, the B slide, that's where the coils go in and kind of seal things off. And it's extremely effective treatment for treating aneurysms. It's not for every aneurysm, but this is kind of what started 20 years ago and just changed the field. So I'll show you a picture from a case of a patient. On the top left, there's this aneurysm that's oblong shaped, kind of looks somewhat sausage-like, and it is aneurysm that has ruptured. So this is super serious. When an aneurysm ruptures, it probably bleeds for like a second or two. No one actually knows exactly how long it bleeds for, but it's not like it's ongoing bleeding or anything like that. It bursts, the pressure goes up really high in the brain, and then it must seal itself off because we wouldn't be able to survive if the aneurysm were to continue bleeding. And so when the person comes to the emergency room, the purpose of treating the aneurysm is to keep it from bleeding a second time, because if it bleeds a second time, it usually doesn't stop bleeding. And so it's like a fragile thing when an aneurysm bursts and the person gets to the hospital. We want to move quickly. We want to move confidently. We want to have a good plan in place because you have like one shot to fix the aneurysm and to make sure that it's sealed off. But there's not a lot of futz factor. There's not a lot of guessing or trying to figure out what may or may not work. We need to know exactly what works. And coiling is like the workhorse for ruptured aneurysms because we know it works most of the time. And the top right is the aneurysm, the picture that we see with the angiogram. And then on the bottom, you can see that there's like this kind of fuzzy stuff that's where the aneurysm used to be. That's the coils that are in there. And the aneurysm isn't filling anymore, so the patient is safe. And once the patient's safe, that makes everybody more relaxed, and then the patient can go on to recover. And I do most of my cases, probably more than 95, maybe close to 98% of cases through the artery that starts in the hand, the radial artery. And so this is it's kind of like a little air bladder that we put over the wrist afterwards just to make sure that there's no bleeding for usually 2 hours or so, sometimes an hour. And I take pictures of it afterwards. I used to take the pictures because I wanted to include them in presentations and talks and things like that. But then I realized how neat it is to be able to show people what it looks like, kind of, because with anesthesia, you don't remember too much, or some of the data is fuzzy because of anesthesia, or you had the ruptured aneurysm and kind of you don't remember a lot of things that were going on in the hospital. But to be able to take the picture and to show patients like, hey, this is what your aneurysm looked like, and this is the spot in your hand that we went through. It's still a very kind of magical thing for me, actually, that we can fix the aneurysms that's from starting in the hand and then to go all the way up into the brain with these small little tubes and wires and to seal them off in a matter of 30 minutes. It's actually each time I do it, it's actually something really special for me. And so that's really why I take the pictures, to share with patients kind of that same kind of feeling that I get, like, wow, it's really something else. I've done this almost 1,000 times now, and it's still very, very. Uh, uh, I'm still kind of shocked that we're able to do it, and I take no credit for developing the technology behind it or anything like that. But it's just really something to be a part of, and feels like something special every time I do it. Ruptured brain aneurysms come in all shapes and sizes. I showed that initial slide where there was that small little bump. Aneurysms can get bigger. Aneurysms can get different shapes. They can be in different parts of that artery tree, in different parts of the brain. And sometimes they're not as friendly. And so we got to take care and kind of plan based on the angiogram ahead of time to make sure that things go smoothly. This is a kind of a big globular aneurysm. It's much bigger than the last one. It's not round. There's a small little bump on it on the top left up there. And that bump is probably where the aneurysm was the weakest and probably where the bleeding came from. And so we take extra caution when I see something like that to make sure that coils go in softly, that they fill that area, that it's no longer filling with blood, and that it's completely sealed off. And so this is a really nice before and after picture. I know the plastic surgeons like to put the side profiles after they do surgery on the web and do for advertisements. I don't advertise for brain aneurysms like this, but during a presentation, it's kind of, this is how I show off a little bit. It's a big aneurysm on the top left, and then it's completely sealed off on the right. And the chance of that being permanently cured are very, very high. And certainly the patient has no trouble getting through the recovery to the next phase of their life with an aneurysm that looks like this. And this is another type of, we started going through the artery where you feel your pulse here in your hand, kind of at your wrist. And then there's even a smaller artery that's on the top of your thumb. And we found that to be even a little bit more safe and more comfortable for patients. And so I've actually started maybe four years ago. I moved over to the majority of my cases through the little artery that's basically at the base of your thumb. It's the radial artery, but you can barely feel it in your hand. It's like right at the base of the thumb. But that's where we put all of our catheters and tubes that we use to get all the way up into the brain. It starts at the bottom of the thumb. So coils are one kind of tool that we have in the catheterization lab to fix aneurysms, but there's actually a lot of other technology that's super interesting and is very well studied now at this point. We have things like flow diverting stents. So I showed the coils that went into the aneurysm before. A flow diverting stent is kind of like a slinky tube. You've probably heard of people having stents in their hearts for different conditions. This is a different type of stent. This is a stent that kind of keeps blood going in one direction. And so if you've ever been on the road where they're doing like some construction or tree trimming or something, there's like that guy that has the sign and he says, slow or stop. And he says slow, and you just kind of keep going in one direction. You stay out of the other lane. You just keep going down where he tells you to go. And so that's what a flow diverting stent is. It's that guy with the sign that says, keep going down in this one lane. Don't go off into the aneurysm. Just keep going straight. You'll be fine. And so flow diverting stents, they've been around for over 10 years now, with tens of thousands of patients treated. And over time, when the stent goes in there, it's not an instant fix, but over time, over a course of probably weeks to months, the blood keeps going down that one lane, doesn't go into the aneurysm shrivels up, scars off, aneurysm's cured. It's a very, very interesting kind of concept, and probably about 30% of aneurysms now are treated with flow diverting stents, maybe more. But it's very safe because you don't have to go into the aneurysm at all. That fragile little area, especially very small aneurysms that are even more fragile, you can put the stent in and stay in that artery and not have to worry about going in there. And there's a very, very high cure rate. And so this is a very, very established technology at this point, over 10 years, and very safe. This is what it looks like from a practical standpoint. This is a very small, this was a ruptured aneurysm, and it's got a really kind of wide stance to it. So it'd be hard to put the coils in there and to keep them sitting still. When they have that kind of wide shape to them, coils have a hard time kind of staying put. So because of the size, because of that wideness to it, this patient was treated with a stent. And it's this slinky tube. You can see it on the x-ray. And we go through the artery in the back of the thumb. That's what the picture is on the bottom left. And then afterwards, the aneurysm has still got some blood flow going into it, but it's less, and it slows down, and it takes time. So it's not like an instant fix, but it definitely changes the whole kind of turbulence in it. And over weeks to months, the aneurysm will seal off, and the cure rate for certain aneurysms is well over 90%, probably closer to 95%. So that's flow diverting stents. Very common in my work, and certainly nothing that we had 20 years ago, but now it's probably 30% of the practice. One of the newer things that we have now in terms of technology is something called intrasaccular devices. It's a really kind of technical jargon term, so I use it for the slide, but from a practical standpoint, if I were to talk to somebody about it, what is it? It's like a mesh basket that goes into the aneurysm. So the coil is like a thread, and it kind of balls up inside of the aneurysm. Intrasaccular devices, they're kind of like the newest thing. They're mesh baskets. They start small, they go into the aneurysm. I release it, it opens up, and then it stays put. So this is an artist rendition of it. We have to get the tube all the way up into the aneurysm and make sure it's sitting nice and stable. But once it's in there, the basket opens up, it kind of bolsters itself against the wall, and it slows down and then eventually stops blood from going into the aneurysm. And so there's lots of different companies that make the device, and like a Kleenex tissue, Kleenex is the name brand, but it's a tissue. So there's lots of different intrasaccular devices that are coming out now from different brands. I won't mention any of them because there's so many, and it doesn't make too much of a difference in terms of this presentation. But the technology is really interesting concept. It's instead of this coil ball that goes in there, it's this mesh basket that sits out and can seal off the aneurysm. Nice part about these devices, you don't need to be on any blood thinners long-term for them. It's like a one device type thing. You don't have to put many coils in. It's just one basket that opens up. And it's very, very soft. That basket looks kind of like a bully on the screen, but in real life, it's actually once it's expanded like that, it's actually very, very soft and very, very safe. And so that's why I like using it for certain aneurysms, especially the ones that have the kind of the wide stance. This is an example of what it looks like in terms of the angiogram. So this is that bump, the aneurysm itself. And then I took a screenshot, like a little picture of the tube all the way up into the aneurysm. You can barely see it because it's such fine little mesh. But when you have a 1-year follow-up, the aneurysm isn't there anymore. It's just completely gone. It's like a magic trick almost. And it works really good. It has a great safety profile. It has not had as much experience as coils or flow diverting stents in terms of hundreds of thousands of patients, but it's definitely tens of thousands of patients in more than 10 years. So it's not like a experiment or something new like that. And it's probably about 25 to 30% of the practice now in terms of how we're treating aneurysms. This is a picture of her wrist where we went through and put the devices in. And it's still just kind of interesting because I remember patients with these very, very large surgical incisions on their heads. And sometimes the aneurysms were so complex, we would have to remove the bone that's above the eye on the orbit and the bone that's on the side of the face here called the zygoma. And then move the eyeball down to sneak under the brain. And now those exact same aneurysms can be treated with these different devices on the inside of the blood vessels in a very, very short amount of time in comparison, and with very, very little downtime for patients in the elective setting. A couple more pictures. This is a intrasaccular device. Top left, you can see the aneurysm itself. And then on the bottom, also you see is kind of these little metal markers where the aneurysm is filled with this mesh basket. And it makes the aneurysm disappear, which is super interesting. 1-year follow-up, aneurysm is completely gone. It's not to say that you can always predict the future, but because there's been so many people and they've done so many trials on these devices, there's some level of certainty that you can communicate, 85% cure rate, 90% cure rate, and then you can tailor that number based on the patient characteristics and what the aneurysm looks like and how well it opened up and stuff like that. And so overall, they're very, very safe devices, very effective. This is another one. I remember this was one of the first aneurysms in the United States that was treated with a web device that I did when I was in Los Angeles in practice many, many years ago. And it's this broad, kind of wide stance aneurysm in a very, very delicate part of the brain at the top of the basilar artery. And I deployed the web device, and almost instantly the blood flow stopped into the aneurysm, and there was like stagnation. And when I saw that, I was like, wow, this is going to be the next big thing, because that area of the brain is very, very difficult to work with, either with surgery or even with coils and things like that. And so this was like a next step forward. I remember this patient quite well. We're able to do things with very, very complex aneurysms on the inside of the blood vessels now as well. This is a vertebral artery dissecting aneurysm, one of those longer sausage aneurysms. And by using the arteries in the hands, you can see on the top right here, I actually tucked the patient's left hand across kind of towards their belt buckle in the middle there. They call it the Al Bundy maneuver. And then the right hand is down at the side where I stand. And we're able to get catheters at the same time to go up into the vertebral arteries to make sure that the coils go in perfectly and that we can take pictures at the same time as putting the coils in to make sure that they're landing perfectly and that they're in a good spot before we release them. And so it's really been kind of an evolution, not just on the inside of the blood vessels, but what can you do with the arteries in the hands, and can you use the other hand too to get better pictures at the same time? And so using both radial arteries for these very complex aneurysms that need more pictures has really kind of increased the safety level and increased our kind of confidence level when dealing with them. We're also able to use combinations of techniques, like we can use the coils with the flow diverting stents for aneurysms that were, some people may even consider them untreatable or with unacceptably high complication rates with other techniques. And so this is a pretty big aneurysm, like 1.5 centimeters almost, in a very tricky part of the brain. And we were able to put some coils in, loosely pack it, make sure that the vision was good, put the flow diverting stent in, and at a year follow-up, the aneurysm is cured. And this is a younger patient that never has to really worry about it again. In the history of the world, they've never had an aneurysm regrow that's been cured with a flow diverting stent, because it really means that the vessel has regrown and you basically started fresh again once the body has healed over. And so a younger patient with a great outlook on life, and it's just awesome that we can offer this to patients. This is another case of a really kind of, people ask sometimes to compare their aneurysms or their tumors to like food or vegetables or fruit. This is kind of like a lime size aneurysm. Patient was developing a little bit difficulty walking and difficulty with vision. And we were able to put some coils into it and alongside of a stent to help divert some of the blood flow away from it and seal it off completely in a single session. And it just changes everything, because once you know that aneurysm is there and that I show the pictures in clinic and people can see it, it's natural to get anxious about it, natural to get worried about it, but knowing that it's gone and sealed off in a single session or closed sessions, it's really something that changes your outlook. And so it's just great that we can do these things on the inside of the blood vessels. This is one of the bigger aneurysms I've fixed on the inside, over 4 centimeter aneurysm. So it's getting up there in size, probably bigger than a golf ball. Patient was developing difficulty even speaking or remembering things. So the memory center in the temporal lobe and speech. And we were able to put coils in and a flow diverting stent and had a durable cure. This is a 2-year follow-up on this patient, showing that the vessels are like completely normal now and that there's no sign of regrowth or anything else like that from the aneurysm. And so there's really amazing things that you can do endovascularly and with the technology that we have now. So just to kind of wrap things up in terms of the main focus of the presentation, the minimally invasive, how we can fix aneurysms through small things. We've moved from what we can see with our eyes under the microscope, these kind of surgeries where we have to go in through the skull and dissect the brain tissue, to this whole new skill set, whole new technology set, where we do everything on the inside of the blood vessels through a little artery in the back of the hand. And it's with device technology, it's with advanced imaging and robotics, kind of those 3 things that have really allowed for that to happen. And so there's nothing that we don't offer at Cottage in terms of technology or technique. It's actually state-of-the-art worldwide. There's nothing that we don't do here, from bypass to the most complex endovascular techniques. And we're actually expanding. There's a really good foundation, and I've been here for a little bit over a year, and I'm looking to kind of move that forward in terms of bringing even more state-of-the-art stuff and more cutting-edge stuff. And so we're expanding kind of the research on the neurosurgery side of things. We have a great research team. We're getting a NIH grant, NIH-sponsored phase 3 randomized clinical trial off the ground as we speak. We just got off the deployment call for it today. And so super excited about that. The Aspire trial, Dr. Taki is taking off with the Picasso trial later this year. But the purpose is not to advertise the research in this presentation. The purpose is to tell you guys about the level of care, the level of the center that we operate. It's not just surgery. It's not just endovascular. We're not like a university only kind of focused on research center. It's that we offer very high level at all of those things, even across through research. And so it's something to be said. This is a research team, and we're going to have new devices. We're going to have stuff that you can't get on a routine basis at other places. And we want to be cutting edge. We don't want to be the first ones, but we certainly don't want to be the laggards behind. We want to be able to offer the kind of the newest, safest, and best things to fix aneurysms that are available. And the rate at which that stuff is developing is so fast that I have to spend a good portion of my day trying to keep up with it, actually. And so that's where research comes in. And I want to spend some time to thank the research team for their help in getting some of this stuff off the ground. And so I think that's kind of the end of my talk in terms of the formal stuff, but I was hoping you guys might have some questions or comments that I can get to.
Thank you, Dr. Walcott. It was such an informative and engaging presentation. We'll shift now into the Q&A part of our session. We've received quite a few really great questions, so we'll do our best to get through as many as we can. Just a reminder, if you haven't submitted your questions yet, type them into the Q&A box at the bottom of your screen, and I'll read them to Dr. Walcott. Alrighty, ready to kick off with our first one. If an aneurysm isn't bleeding, how can it still be diagnosed?
So good question. The question is like, how do you find out you have an aneurysm if it isn't bleeding? And it happens for a lot of different reasons. Sometimes people get CAT scans for they're in a car accident and then they find it. Some people have an MRI for unrelated reasons. Say they had like some sort of earache or sinus issue. A couple of people that were in the presentation today, in terms of those pictures, they discovered their aneurysms through, they were getting like pictures done for their sinuses. And so a lot of the times it's incidental, meaning it's just kind of found by accident. But there's no real reason actually, and this is a recommendation from the American Heart Association. It's not to worry the general population with screening for aneurysms. I think it's wrong to recommend just going out and getting scans just to see if you have one or not. I don't know if I have one because I've never had a scan, so take that for what it's worth. I don't think that general screening is good. I think if you had like 2 family members, the recommendation from the American Heart Association, if it's 2 close family members, is to get screened because there's probably some genetic thing going on there that you should look into closer. But it's not like for breast cancer, we have the mammogram. For colon cancer, we have colonoscopy. There is no screening test for that's widely recommended for brain aneurysms. A lot of brain aneurysms are found by accident. So yeah, they're usually found by accident.
Okay, great, thanks. Actually, this is a perfect segue into the next question. Someone asked, if someone has a family history of brain aneurysms across multiple generations, how concerned should they be about their own risk, especially as they age?
The official line from the American Heart Association is two close family members, meaning first-degree relatives. So like brother, sister, mother, father. Everyone's different though. Like I don't practice medicine, like I don't like open the textbook and like preach to people like what's in the textbook or like what the American Heart Association guidelines are actually. If somebody's like worried about it and they've had like significant stuff in their family and it's like across a couple of generations, it makes sense to like put that person's mind at ease and to get a test. There's no radiation with an MRI. But it's a balance. Like you can't screen everybody, and it doesn't make sense to screen everybody. But if it's really bothersome to somebody and it's had a huge impact in their life because of family members, especially if there's like two or more across generations, then uh, I, I think it's okay. I would argue with the insurance companies to cover it.
Okay, great. Thank you. Next question. What materials are used to make the coils used in aneurysm treatment? Are they metal, plastic, or something else? And are patients still able to safely undergo an MRI after coil placement?
So the coils are made out of like a platinum alloy, and they're totally okay with MRI. They haven't made anything in the past like 15 or 20 years that's not MRI compatible. And so MRI is good. And yeah, it's like this metal alloy compound that's made based with platinum, actually.
Okay, awesome. Thanks for that explanation. Let's see. The next one. When do you treat an aneurysm with a flow diverting stent versus coil embolization versus intrasaccular device?
It's like the big question.
Yeah.
So it's like the art of medicine. They say it's like, the art of medicine. There's like an art to it. So there's different like textbook things like, hey, wide neck aneurysm, you should treat with a flow diverter. But you could also use an intrasaccular device for some of those aneurysms too. Sometimes it comes down to very specific anatomy, like what do the curves look like on the artery? How curvy is the artery in the neck? How hard would it be to get a stent all the way up there? Is the patient able to tolerate antiplatelet drugs for a couple months? Or do they have a history of like bleeding ulcers that would, keep you from having like blood thinners? So there's actually like this laundry list of things that go through in my mind. If something looks like it's like could be treated either way, I usually have a personal favorite and I'll just tell people that in clinic. But sometimes there's other things too, like blood thinners and stuff like that, that are like important as well. But there's many different ways to treat even a single aneurysm. And so it's not super clear cut. I usually try to bring up the pictures and show people like kind of like what it looks like. And yeah, it's not like one or the other. Usually it's like you could kind of do multiple things. Which one do I think is the best and safest with the highest cure rate?
Awesome. Thank you for that. We have two questions about what happens with a little basket. What happens with the basket once it's healed?
The basket's there forever. The basket's in there forever.
Okay.
So it actually, I followed a couple of people now for many, many years. So the aneurysm kind of like scars down or shrivels down a little bit. The basket will actually change shape a little bit. Like you can see on the x-ray, the basket will like kind of shrivel up to a little bit, but it has an intrinsic size. So that the basket itself has a sizing to it. So they have like dimensions that when you order them, they come in a box. It's like 5 millimeters by 3 millimeters, 4 millimeters by 2 millimeters. It's a soft basket, but that's like the general size that it'll take. And so yeah, it goes in, it's in there forever, and then it'll scar down a little bit and it'll change shape a little bit, but it's in there for good.
Okay, thank you. What are the root causes of aneurysms? Can they be a one-time issue, or are they likely to pop up multiple times in one person?
Very rare to have more than one aneurysm. It's probably like 5% of people. The root cause is not entirely known. There's two things that are associated with aneurysms. Now, it's not cause and effect. It's not that. So smoking and high blood pressure, smoking cigarettes, high blood pressure. Lots of people do both. Not everybody has an aneurysm. So those are just associations. So there's lots of people that have never smoked a cigarette and have normal blood pressure and they still have aneurysms. So it's not like this one-to-one thing. But if you were to look at like 1,000 people that have an aneurysm, there's a bigger percentage of them that have a history of smoking cigarettes, history of high blood pressure. So if people come into clinic and they have like a small aneurysm and we're just going to kind of like watch it from year to year to make sure it kind of stays well behaved, that's the two things I tell people. Keep your blood pressure under control, ditch the cigs.
Great, thank you for that. What are some common I can't speak today. Telltale symptoms of an aneurysm without having had a scan?
Nothing. So typically an aneurysm will have no symptoms whatsoever. Sometimes like the big giant one that I showed you, like the lime size thing, that can push on cranial nerves or can cause personality changes. That's extraordinarily rare. That's like one in a gazillion type thing. But most aneurysms, if they haven't burst, produce no symptoms whatsoever. And then the one symptom that people should look out for, like not like look out for, like you don't walk around thinking about this, but if you have a severe headache that just starts like that and it's the worst headache of your life, that's like a sign to get, that's not something to ignore. So like sometimes people have headaches all the time. I get headaches from every now and then. It's not like too big of a deal. And sometimes I get a bad headache and that's not like, I know not to worry about that too. But like if you're a person that like doesn't have headaches and then all of a sudden it's like one like monster headache that comes on like a lightning strike, that's like, and even if you do get headaches, but it's like different and it's like a lightning strike headache, that's when you want to seek care. You don't want to like have to come in a week later, you know, with the aneurysm bursting twice or something like that. So like really severe headache, they call it thunderclap or lightning type headache where it like really gets you. Not like a stress headache, not like a migraine. This is like something that you would know if it was happening to you. It's just not to brush it off. And so it's not something you walk around thinking like, oh, I got to watch out for that lightning headache. I'm just saying, like, if you get something like that in your lifetime, which is extraordinarily rare, if something like that happens, you shouldn't. That's one thing that you shouldn't brush off. I don't trust a lot of doctors. I don't like medical care for the most part. But if I had a lightning like thunderclap headache or something like that, that's the one thing that I would immediately seek care for.
Great advice. Thank you. Are blood thinners required for life for all patients after a successful aneurysm procedure?
No. So the flow diverting stents we use blood thinners for, and some other stents we use blood thinners for, but it's for a period of time. It's not indefinitely. And so the reason that we do that is the metal can cause blood clots on the metal of the stent itself. And it's like it's something foreign in your body. Your body's like, hey, what are you putting in me? This isn't natural. And so your body like forms a clot on it and it could cause a stroke. And so the blood thinners, that's how they work. They keep the blood going and they're like, hey, just, let the body heal. You get a nice little layer of scar tissue on there. And then down the line, many months later, you can stop the blood thinners usually. Coiling, you don't typically need blood thinners for it because all those coils are on the inside of the aneurysm. They're not in the artery. And so there's much less risk of stroke with that.
Okay, thank you for that. Next question, how long does it usually take to repair an aneurysm?
Different for everybody. If you were to do the surgery, the craniotomy, those typically take 3 to 4 hours. The process is long. There's a lot of steps, and it's under general anesthesia in the OR. Endovascular, treating it with coiling or flow diverting stent or one of these intrasaccular devices, typically takes somewhere on the order of like 30 to 45 minutes once things get going in terms of the technical time. But it could be faster than that. It could be a little slower than that. everyone's a little bit different. That's just kind of like generalities in terms of 30 to 45 minutes.
Okay. And then follow up to that, how long are people usually in the hospital for an aneurysm repair, or does that vary?
It varies a little bit based on whether there was bleeding from the aneurysm or if there was no bleeding from the aneurysm. So if we're fixing it as like a preventative thing, most people are in the hospital for one night, and they're usually like walking around later in the day, the same day of the procedure. But we watch everybody in the hospital. It's been the standard. There's some places that are doing same day discharges. We don't do that here. But even if you're just like watching TV and hanging out, it's usually one night in the hospital. If you had bleeding from the aneurysm, you're going to be in the hospital for a while though. So you'll get to aneurysm repaired, but then we have to watch you for all these kind of things that can creep up after the bleeding has happened. And people are usually in the hospital for about 2 weeks, as long as everything is nice and smooth.
Okay, great. Well, we're going over time now, so I'm going to ask one last question before we close. Thank you all been so informative and so many questions. When an aneurysm is fixed, are issues with walking, talking, balance, seeing, hearing, are they regained?
So understanding the question, I think somebody is trying to ask, like they had some issues related to the bleeding from the aneurysm, then the aneurysm's fixed, like will the other stuff get better? The frank answer is no. It doesn't change how the brain heals at all. And so the purpose of fixing the aneurysm is just to keep it from bleeding again, which could be catastrophic. Once the aneurysm's fixed, then the brain can kind of like focus on like repairing itself and healing. And so in that sense, it kind of helps things. But there's no it doesn't directly improve the blood, it doesn't improve the neurons in terms of helping arms and legs move and speech and stuff like that. That stuff takes time, and the brain has an ability to rebound, but everybody is a little bit different.
Great, thank you so much. So that concludes our Q&A session. Thank you, Dr. Walcott, again, for all of your knowledge, and everyone, thank you for submitting your questions. Dr. Walcott serves at the Cottage Neurosciences Clinic, located at 2410 Fletcher Avenue, Suite 302 in Santa Barbara. For more information, please call 805-569-7820 or visit cottagehealth.org/neuroclinic. Immediately following this presentation, you will receive a link to request more information or have a member of Dr. Walcott's team reach out to you to make an appointment. We'll also email a recording of this presentation later this week, and a brief survey will appear after this webinar closes, and we'd love to hear your thoughts. So thank you again for joining us, and have a happy and healthy rest of your evening.
Thank you, everybody, for your time. I really appreciate it. Thank you.